Hi everyone, good evening, and I hope you've had a great break. My name is Sayantan. I'm a working editor with the Indian Journal of Medical Ethics, and it's my pleasure to welcome you back to the 10th National Bioethics Conference. This is the third session of the conference, the second on this day, and the session is titled AI and Marginality. Users' perspectives from transgender persons and people with disabilities. As the name conveys, we're going to largely talk about how the AI, we'll largely be talking about how the AI boom might be intersecting and affecting and integrating with the lives of people facing different marginalizations in the society. Um, Of course, in one session, it's not possible for us to cover all different marginalized identities and marginalized groups. So, what we've decided to do for this session is keep our focus restricted to broadly two marginalized groups or marginalized identities. We are going to hear largely from transgender people and people with disabilities. Uh, and when we talk about disabilities, we both talk about temporary and more longer term disabilities. Um, the idea behind this session is, and the idea took birth when we started thinking about how AI tools might be, were being touted as being very helpful for people with disabilities as the next forefront of what we call assistive technologies, right? So there was a suggestion that voice and facial recognition software, speech to text and text to speech softwares, sign language avatars, mental health support bots, all of this would revolutionize the way people with disabilities might be accessing and interacting with the world. And we started wondering if AI tools are now being touted as the next great equalizer. And almost all of us on this panel have worked in different scales with the two communities that I mentioned, transgender people and persons with disabilities. And we started thinking about how much of truth is there to the question of AI tools being the great equalizer. And we didn't at all want to come from a position of denying the fact that that AI tools might be very, very helpful. So what we decided is then to bring in people who are transgender, who are living with disabilities, and we decided to start thinking about how these opportunities for inclusion, equity, and access that AI tools are being touted to present, how do they sort of stay alongside the challenges that the increasing integration of these tools into our lives might present. So, for example, I had done a report a couple of years back where a lot of transgender persons had suggested that the facial recognition technology that was being used by Digiyatra might end up either miscategorizing them in a wrong gender, or it might actually impede their access to the airport entirely if people are either if their faces don't match what is in the database of Digiyatra. Similarly, there have been some concerns raised by people with psychosocial disabilities that if there are AI tools that are used to track body language during interviews, they might be unfairly discriminated against. And all of this is happening keeping in mind the kind of discussions that we've had about bias in the last couple of days, the kind of discussions that we've had around privacy and security of the data that is gathered by these tools, and finally, concerns around the accessibility of these tools themselves. So, for example, the Arogya Setu platform, I know it is not an AI tool, but given that it was a health technology, digital health intervention, was, for example, not accessible to people with disabilities. So these are just a couple of notes that I'm presenting before we start this discussion. The idea behind this panel is to understand these opportunities and challenges and do so center staging the experiences, concerns, and aspirations of transgender persons and people with disabilities. The reason why we also talk about aspirations is because we know that a lot of AI development and deployment is happening on the tech side of things, but we frankly don't know how much of that development is and deployment is happening listening to the voice of the users, particularly users who are marginalized, whose voices are minoritized, and perhaps harder to reach the developers. So we hope that this is a starting point for more conversations. And with that, what I'd like to do is welcome my co-chair, Shampa Sengupta, to the table as well. Shampa is an activist with more than 3 decades of experience in working for disability and gender rights. She's the founder of Shruti Disability Rights Center and serves as the Joint Secretary of National Platform for the Rights of the Disabled, which is India's largest membership-based cross-disability network. I'm really honored that Shampa could join us for this session and agreed to chair this session at frankly an absurdly short notice. So Shampa, thank you very much for finding the time to join us and help lead and moderate this session. We have 3 speakers, and the first of them is Mridul. And I believe, on at least on this table, Mridul is perhaps the only engineer on in this panel. So, and perhaps one of the very few who we've been able to mobilize for the conference as a whole. Mridul is a full stack tech professional who spends most of his time building AI enabled accessible technology products for persons with disabilities. And there's a lot of things that Mridul does. You can read about his bio. I'm dying to hear from him, so I'm not going to read all of it out. I hope, Mridul, that's all right. But Mridul, alongside his life as an engineer, the way I know Mridul is through the immense amount of community work that Mridul does, drawing upon his interests, politics, and experiences. He's a trans man and has worked closely with queer trans collectives in Mumbai and across India for about a decade and a half. He's currently a member of Hasrate Zindagi Mamuli, which is the journey or the tales of a life that lives that are ordinary, which is a Mumbai-based queer trans collective focused on advocacy, crisis intervention, and collective care. I'll leave this to you, Mridul. Thank you very much for joining us.
Thank you, Shantan. Okay. So since we this part of like my presentation is called Health AI Revolution or Reinforcement of Old Biases, I thought we can probably spend a couple of minutes and start by looking at the ways in which health AI is used. And this again, this is not an exhaustive list. This is just based on what I know and the information that I could find. So broadly, there are sort of 3 main ways in which AI is currently being used within the health context. Uh, One is sort of as assistants for non-medical professionals, like for people like us who actually are not medical professionals, but we sometimes will use it for sort of checking symptoms, asking specific questions. This body part is hurting, that body part is hurting. What could it be? Like the kind of stuff that Google used to do earlier. Now health AI some at some places is being used for that. Uh, there are some sort of automated diet chart generators or things like that, like Healthify Me, for example, ADA, Tap Health, MedGPT, some examples. Again, so I'm going to be I'm naming some examples because it's just the information that I could find and some of the products that I knew of. Anything that I'm naming here, please don't think that that is being recommended, because there are issues with all of it as we're going to just go ahead. This we're going to find out when we go ahead. So some of these are being used. There is some assistive technology specifically meant for persons with disabilities. So there's some AI being used there, and there are some very specific chatbots, uh, which serve a specific section, like questions about something specific. So that's again, all of them broadly come under assistance for sort of average people, non-medical people. Then there are some specific assistants that exist for persons in the medical profession. So things like Cure AI, Viz AI, Path AI. So some of them are being used to analyze reports, to analyze scans, to help doctors with case histories, to sort of consolidate information about the patients, especially if the patient has come from another place, and some advice based on, okay, so if these are the symptoms, this is the possible cause, these are the possible this is the possible diagnosis, this is the possible way to treat. So some kind of that similar help, but from a medical perspective for doctors. So that's the other context in which it is being used for health. And so these are sort of more direct interactions as far as sort of everyday healthcare is concerned, like where you are unwell and you go to a doctor, and then the doctor treats you. There are some indirect ways in which AI is being used. So one of which is medical insurance. So generally with medical insurance companies, they use AI to process claims faster, or they're using it for what they call fraud detection, which is like actually a problematic term. We're going to look at that in a bit. But so for fraud detection, in medical insurance is another example where AI is being used. Uh, Supply chain management for hospitals and for pharmacies, for other care centers. So that's where just sort of resource planning, ordering stuff, booking, keeping enough beds available, hiring temporary staff whenever that is required. So that kind of resource planning based on, okay, it is flu season, stock up on these medicines, or uh, there's like too many festivals coming, probably, have some extra people for taking care of people who are going to fall ill around that. So those kind of things, AI is being used there at some places. Um, and then public health and disease prevention. So where it is mostly being used for data monitoring and analysis. So for example, preparing for pandemics, we saw one not too long ago, uh, or sort of seasonal changes that happen, and that generally cause for people to fall ill. So that kind of disease prevention and some sort of public health management is where the AI is being used. Now, this is what is being generally understood. So when we say health AI, this is what generally comes to at least my mind, and I would assume to the minds of most people. So broadly these categories. And then there are some other uses of AI that we observe within the digital context mostly, which don't get touted as health AI per se, but the way I read it, I think it has an impact on our health. So when we talk about health AI, when we talk about AI and healthcare, I think we should also talk about those. So one example that we'd all be familiar with is something like, let's say, our social media feed. Now, our social media feed has nothing to do with sort of taking care of our health per se, but I think it does have an impact on our health, and in multiple ways. So again, so let's sort of keep in mind that the purpose of the AI engine behind the social media platform that you are going to and that is showing you the feed is to keep you there for as long as possible. If keeping you there means showing you misinformation about how you should have turmeric in your milk, or how the egg yolk is bad for you, or how a specific diet is the way to longevity and everything else just doesn't make sense. So if that kind of misinformation is the way to keep you there, that is what uh, it is going to show you, right? And I think that does have an impact on our health. I mean, whether you believe it or not, if you believe it, yeah, it's going to have a different kind of impact on your health. But if we don't believe it, even then it does have an impact on our health, seeing that kind of repeated information over and over again, or showing us this very cis heteronormative, very mainstream idea of what perfect bodies look like. They bombard us with those images. I think that also has an impact on our health. uh, or whether, again, because anger keeps us sort of more stuck to a platform, right? Anger keeps us, so if you see something that makes you angry, you're going to share it, you're going to talk about it, you're going to react more strongly to it. And so whether it is showing us content that makes us respond more angrily, that makes us respond with sort of uh, more aggression, for lack of a better word, I think that also has an impact on our health. So that's sort of one example which doesn't get counted as health AI. But when we're talking about AI's impact on health, I think that in the larger context should also be looked at. Or it's something it could be something like, the prediction engine that serves as ads. So it will pick up data from wherever. So let's say you looked for, I don't know, some ailment, or you ordered some I don't know, let's say some constipation medicine from Amazon. And the next thing you know that you're listening to Spotify, or you're listening to you're watching something on Prime, and then all of a sudden that the same uh, ad for the same medicine, because now that network knows that this is an ailment that you have, they show up. So it can at worst be sort of just embarrassing at times, but it could also be dangerous, depending on what is it that you look for. I mean, if what you look for, the ad related to it, uh, discloses your identity without your consent to someone who it is not safe for you, then that also becomes dangerous. And I think that has a direct impact on our health as well. So that's the ad prediction engines and the privacy concerns that come with. So I'm just introducing a couple of different ideas here. We're going to go into them in a little bit more detail as we go ahead. But I think that's another area which we should, like, when we're talking about the impact of AI and healthcare, I think that is another area that we should think about. Or it could be something, as unrelated as that auto transcription engine. Uh, the auto transcription engine that many offices use. So you are in a meeting, right? You've joined a meeting, and there are all of these auto transcription tools that many offices use. And then I've actually heard about it from a couple of my friends who haven't undergone medical transition yet. They haven't had any medical intervention, so their bodies still are not in sync with their true gender. And the auto transcription engine will always misgender them. They might be able to pass otherwise in a real life, sort of in an offline meeting. They may not be able to pass, but with the AI engine, there is no way to negotiate that, right? So a trans man who hasn't undergone the medical intervention will always get addressed as she by those engines, and that triggers dysphoria, of course. That makes things awkward, like, to say the very least. And then that has a very direct impact on health, even though you would think an auto transcription software for recording online meetings, what could that have to do with health? But it does. Having said that, there's some good use cases also. For example, an app that enables a person with ALS to communicate. That I would say is one example. Or a chatbot that collates all these jugaad ideas from persons with disabilities and makes it available to other people with disabilities or their caregivers in an audio enabled and language agnostic way. Now, those two examples I just gave, that's a bit of a shameless self plug. Those two are my projects. Uh, to look beyond sort of my own project. So a chatbot which basically makes it possible for let's say AFAB people, like assigned female at birth people in remote areas where they might not have access to a lot of doctors, a lot of information. So SRHR chat, sexual and reproductive health and rights chatbot, that actually makes that information available in a comfortable talking to, where they can openly ask questions that one would feel uncomfortable asking to other people around you. So a chatbot like that also would be a good idea, or something as simple as like a travel coordinator, where a bot or a tool that knows your history, that knows among other things, let's say the fact that whether you're trans or not, whether you're queer or not, and if you're planning to travel to a particular location, it actually just analyzes information, not just about what kind of allergies you might be prone to, or what kind of weather you might expect, but also what are the laws there. How friendly or non-friendly is general public to people of a certain sexuality or people of a certain gender identity. So there are some good use cases also of it. But then, actually, in theory, all these ideas that we get sold, right? All these tech, AI, health products that we hear about, that we know about, they all sound like good ideas because that's how they get sold to us. And I mean, there is possibility for good at a lot of those places. So even something as simple as uh, a tool that is generating, let's say, meal plans for you, right? Easy to follow meal plans that fit your lifestyle. I mean, in theory, that is a good idea too. Uh, so all good ideas, but then the moment you start thinking about who all gets left out, then you start to see holes uh, in those narratives. Like, for example, the medical insurance example that we just talked about a while ago. Now, if you have, let's say, a medical insurance uh, with any organization. Now, in India at the moment, there are two ways that you're going to have a medical insurance. If you uh, if you don't want to completely sort of hide the fact that you're trans, right? Or if you are pre-transition and you're still going with your assigned uh, sex, if you're still going with that assigned identity, then that's a separate story. But then also it will not cover a lot of things that might become relevant for you later. But then if that cat is out of the box, so to speak, then there are only two ways you can have a medical insurance, right? So one is that, if, for example, if I went to get a medical insurance, I will not disclose the fact that I've transitioned. So that's one way to go about it, right? You get that insurance as male. They're going to look at you. Somebody will come at you, and then unless there is a history of specific health diseases, they'll probably not ask for a health record, and you get that insurance as male, as a whatever XYZ year old male. Second is you actually are open about the fact that, okay, I am a trans person and I have medically transitioned. This is my history, and this is who I was. This is how I identify now. So that's the second possibility. Second is a little more unlikely. And but then if you have if you have an identity card that says T on it, which is again a possibility for some of us, then that is probably the way that one is going to go. Now, a medical insurance company using AI to reject or accept claims, and the fact that you, as a trans person, I could get a medical health insurance, they sound like sort of very unrelated facts. But then the moment you combine the two, you realize that troubles are going to arise. So now, if I had not disclosed the fact that I have transitioned, then a lot of conditions that I might suffer from, or that I might need some sort of claim adjustment from, they go out the window, right? Because if you are a male, how can you have this particular disease? Or why do you need care for this particular condition, right? So that's one possibility. If you had disclosed, and let's say if you are lucky enough, or more than lucky, I should say, if you're privileged enough, and you do get that insurance, then you will still be categorized as high risk, right? Because all marginalized people, we know this from history, sooner rather than later, they're going to get all categorized as high risk. And what that high risk means is, of course, in different contexts, that means different things. And then you're going to either all your claims are going to get rejected, or you're not going to get insurance at all. So that's just one example of why. Because the data on which these AI systems that feed into those fraud detection mechanisms, right? Again, how do you define fraud? So those fraud detection and processing mechanisms rely on, they haven't seen enough information about trans people. So then either you don't understand it at all, or if you understand it, then you get sort of one limited version of it, high risk. Because again, one this might be a lot of detail, but then one example of that would be, so how these in insurance terms, a high risk patient is like somebody who has a higher chances of claiming the insurance, right? If you have only a very limited number of trans people, and let's say a majority of them do claim for a specific condition, gender affirmative care is currently, it's not covered under medical insurance in India, so that doesn't apply. But in other places where it does come under medical insurance, they all get classified as high risk, because many of them do use their insurance to take care of their gender affirming care. And then as a result, not all trans people go for medical interventions, right? Even trans people who have no plan of, or who have no plan of going for gender affirming care, or those who have already uh, done what medical interventions they needed to do before they got this insurance, they also get categorized as high risk, and they're going to end up paying higher premiums than what they should be paying. So that's one example. The other example is, again, the other example we saw was when either doctors or people like us, right, non-doctors, we were actually using AI to figure out, what could this symptom mean, or these two symptoms combined, what could this indicate? So it could be doctors doing that, especially younger, newer doctors, and that gets said a lot, right? So especially in India, it's a known thing that in rural places in particular, you don't have that easy, far off places in particular, you don't have that easy availability of doctors, and most of the time the doctors that end up going there and working in public hospitals, for example, are the sort of newer doctors, and they have to do it as part of their residency. So this gets said a lot, right? That with this tool or with that tool, it's as good as that doctor, that one young doctor carrying sort of the experience of 50 older doctors with them. What doesn't get said is that it also means that one doctor is now carrying the biases of 50 other doctors with them. Because with any AI, not just with health AI, it's going to reflect whatever data you feed into it, right? So if the data that you're feeding into it is biased or misses a particular section of population, your AI model has no way of knowing that, okay, this bias exists, or this section of population is completely missing from it. So in that other example that I was saying, so let's say if you're using a tool to diagnose something, to understand what those symptoms mean, and people like you are not represented in the data that was used to train that AI, then I mean that you're going to get misdiagnosed, right? Because it doesn't know the realities that you represent. So that's one aspect of it. The other aspect is actually something that I particularly care about a lot is this increased monitoring. So, I mean, there's a lot of data about us that has been available with a lot of these big companies, with the governments, with states, with all of that. But thanks to the newer advent in technology, right, which includes big data, which was the last big boom before AI. So big data and then AI and the interfaces that the combination of these two have presented, it has become a lot easier for more powerful people, the power centers, whether those are oligarchs or those are governments or whatever, to monitor the rest of us. And I think AI and these tools that have been developed have a role to play in there. And I mean, in the larger sense, if you define health, I mean, if you understand the fact that not feeling safe or having your sort of social securities challenged at all times have an impact on health, then I think within the larger context of health, this needs to be thought about as well. Very quickly, in terms of sort of uh,
You
what is
have
it that
2 minutes? Can you wrap up in 2 minutes? Sorry.
yes, that's why. So just quickly wrap up in 2 minutes. Uh, uh, so in terms of what can be done, there's a lot that needs to be done, but since we just have 2 minutes, so just very quickly just to go through the list. So focus on privacy, some essential rules around privacy and inclusive data. Those two go hand in hand, right? You can't have inclusive data without focus on privacy because that puts more people at risk. Uh, Health monitoring. So the health monitoring of the health AI itself to basically understand where all does the data come from, where all does it lack transparency in where was the data collected from, who collected it, who worked on it, how was it trained. So that kind of transparency is required. Partnership between different stakeholders, which will only come once transparency happens. Representation, not just in data, but also in people that are working on creating these systems. Because it is impossible, and I really believe it is impossible to actually have a nuanced implementation of any of these large scale systems unless you have enough representation from different sections of the society, not just in terms of data, but also in terms of policymakers, in terms of people who are making the decisions, and then a little bit of self regulation within the AI and responsible innovation. So those are just a couple of things, couple of sort of quick action points that I think uh, should be thought about if you have to sort of make AI more inclusive and help it uh, not get rid of, but at least help curb some of the biases. That was it.
Thank you very much, Mridul. It was really very enlightening to. We definitely cannot live without the whole AI that's been part of our life now. But how much inclusive is it? And I think for me it was very important when you say who all are left out. And we all know that there are so many kinds of biases, discrimination that is uh, increasing because of AI. So at the same point, we are having so maybe someone in the rural areas may get access to some information or some health related issues, yet the issue of privacy is something that we cannot be forgetting about. Our next speaker is Mukul Pandya. Uh, Mukul is an associate fellow at Oxford University Business School and a consulting editor of Oxford Business Review. He's the founding former editor-in-chief and executive director of Knowledge at Wharton, the web-based journal of research and business analysis published by Wharton School of the University of Pennsylvania. For business and Wharton custom. Mukul has won 4 awards for investigative journalism and has more 40 years of experience as a writer and editor and he co-authored Lasting Leadership Knowledge at Wharton on Building Corporate Value, and written and co-authored or edited 3 other books. In 2020, he edited an award-winning book, Transformation in Times of Crisis, by Nitin Rakesh and Jerry Mint. So I welcome Mukul, and I'm looking forward to hear from you.
Thank you very much, Shampa. That was a very kind introduction. And my gratitude to all of you, especially the organizers of the National Bioethics Conference. It's been a great conversation. I really enjoyed the two keynote speeches today from Barry and uh, and from Anita, and I'm very happy to be here with all of you today. As Shampa said, I have been working as an editor for more than 45 years, and I was disabled in September of 2021, soon after my retirement from Wharton by a stroke. And at about a year later, I went through a tough time, and a year later, I started I wrote an essay describing how AI had helped me to become active again professionally, uh, and I wrote an essay about it called "How I Learned to Write Again." So what I'd like to do today is it's a first-person account told from a patient's perspective of how AI has worked in my life, and what it has meant in terms of my health conditions and my disability. So I'd like to read the first part of my essay to you, then walk you through some of the AI tools that I've been using, and then just maybe we can have a conversation if you have any questions about any of this. So so this essay was written in October of 2022, about a month before OpenAI introduced ChatGPT. So just bear that in mind as you're listening to what I'm saying. One morning last September, I fired up my desktop computer to answer a few emails when I noticed something weird. My fingers had stopped listening to my brain. They kept hitting the wrong keys. If I tried to type the letter A, the pinky finger of my left hand would hit caps lock key, and I had to go back and retype what I had written. After a few minutes, I realized that it was just my left hand that had become disobedient. The previous day, I had returned at midnight from Florida after a day packed with medical tests and meetings at the Mayo Clinic near Jacksonville. I'm still exhausted from my trip, I told my wife, Hema, and daughter Tara. I should take a nap. I went back to bed. A few hours later, when I woke up, Hema and Tara were in a state of agitated alarm. We need to take you to the emergency room right now, Hema said. We shouldn't waste any time. Oh, I'm fine, I replied. I'm just tired because of yesterday's trip. Denial runs in our family. Tara burst into tears. Dad, please listen to Mom and me, she said. I looked up your symptoms online. We have to leave for the hospital now. My daughter's tears melted my pig-headedness, as they usually do. At the hospital ER, we had barely begun to describe my symptoms when I was moved to the top of the priority list. The triage nurse asked me to hold out both hands, palms upwards, as if I were holding a pizza box. While the right hand held steady, the left hand swayed gently downwards, like a feather that swings back and forth in the air as it floats to the ground. Stroke alert, she called out, and then all hell seemed to break loose. Nurses appeared out of nowhere, strapping me to devices to check my vital signs. The rest of that day is a blur. Later that night, I was told what had happened. As a neurologist explained, I had had what is called a pontine lacunar stroke. It occurs when an artery that supplies blood to a deep part of the brain is blocked. Overnight, I lost the use of the left side of my body. In her 1997 novel, The God of Small Things, Arundhati Roy, the Booker Prize-winning author, writes about how life can change in a day. No one knows the truth of that statement better than a stroke survivor. After a few days at the hospital, I was transferred to the St. Lawrence Rehab Center, a facility that serves inpatient and outpatient stroke survivors. While I was fortunate to have medical insurance that could cover the cost of treating my condition, I was in shock. I could hardly believe how dramatically my life had changed in just a matter of hours. I could no longer walk. The only way I could move around was in a wheelchair. I began to slur my words, although after a while I could sense when my tongue was about to mangle a word and change to a different one. I found myself becoming infantile in many ways. Since my hands sometimes threw food around while eating, the nurses had to place a bib around my neck at mealtimes. What bothered me most was the hell of being helpless. I became over-dependent on my family, friends, and caregivers, who were saint-like in their kindness, patience, and support. Despite my best efforts at trying to stay positive, I had miserably dark days. Hema and Tara came every day to the rehab hospital to see me, but often I sat sullen and silent during their visits. The main reason why life felt so bleak was the conviction that 3 months after my retirement from Wharton, my professional life was over. After more than 40 years as an editor and writer, I could neither write nor edit. If I could not be a writer or editor, who was I? It was a catastrophic crisis of identity, which every stroke survivor goes through. Deborah Meyerson, a Stanford professor who suffered 2 strokes when she was in her 50s, explores this theme in her remarkable book, Identity Theft: Rediscovering Ourselves After Stroke, which she co-wrote with Danny Zuckerman, her son. Like many men and women whose sense of self-worth is tied to their professional identity, in my case, writing and editing, I questioned whether life as it had become after the stroke was worth living. Well, I did not become actively suicidal. On the darkest days, the words of La Barcinara, a revolutionary during the Spanish Civil War, echoed through my mind. It is better to die on your feet than to live on your knees. I reached out to a friend for information about an organization in Switzerland that helps people end their lives legally and painlessly through euthanasia. Today, more than a year after my stroke, which was followed by 2 heart attacks, I'm much further along the road to recovery. I have learned that recovery does not mean fully regaining the capabilities that I had before my stroke, but coming to terms with my post-stroke capabilities and building a meaningful life around them. This was the first of many valuable lessons that I learned from Meyerson's book, which my former Wharton colleagues and friends Catherine Klein and Adam Grant have endorsed. They both generously offered to introduce me to her. I have also come to recognize that to recover, I had to heal my body, heal my mind, learn to love, appreciate how much love I had in my life, and learn to use but not overuse technology. These 4 factors, like the wheels of a car, can get your life rolling again after a crippling disability like a stroke. Today, I will write about the 4th factor, technology, and about the other 3 in the future. So there I'll stop reading my essay, and then I'll walk you through some of the tools that I used to start building a meaningful life. As I explained in the first part of what I read, I was in a pretty dark place. But because I had been a senior fellow in the Research Center for AI and Analytics at Wharton just before my retirement, as soon as Identity Theft, Deborah Meyerson's books, helped me to get my mind in order, I was able to look around to see what technology tools I could use to see if I could regain some sort of independence. And many of them were very simple. And in fact, in retrospect, with everything else that has happened through AI, you might see these are very obvious. But Google and Apple had various tools that I could use. Like for example, on the iPhone, if I wanted to respond to an email message, uh, it had a feature where if I wanted to type, I'm going to there's a feature that would automatically suggest the word hospital. And if that was correct, I just had to tap it, not type it. And that made it possible for me to start answering emails and text messages again. Now, immediately after my stroke, it was Hema and Tara who had done it for me. But the fact that I could start responding to email myself, start responding to text messages myself, it was like a ray of light breaking through the darkness. It gave me some of my agency back. And that encouraged me to keep going further. Now, the various friends of mine suggested, including a dear friend called Karthik Hosanagar, who's written a wonderful book called The Human's Guide to Machine Intelligence, which is about AI and analytics. He suggested using various speech-to-text programs. I tried out a few of them, and they were extremely frustrating because very often they would not, I was still slurring my language and I could not, they would not understand what I was saying. So the messages I got back were filled of errors. And it was so hard to just go back and it was like doing twice the work. So I just gave up on those programs. Then I found an intermediate solution, which is, WhatsApp, as you know, has a recording feature where you can just press a button and record voice messages. And that worked extremely well for me because I was able to communicate what was going on with my health and the privacy of a feature in WhatsApp was beneficial in that regard to leave detailed voice messages for people. And I didn't have to worry so much about whether my fingers are doing the typing right or not. So that helped me a little bit, but that was mostly for personal interaction. I still wasn't able to do any writing or editing. And so that basic question which I raised earlier of identity, if I can't be a writer and editor, who am I? That was still, a really big issue. What changed my life in that regard was, I explained this in much more detail in my essay, which is on my LinkedIn page, if any of you want to read it, is becoming aware of a tool called Otter.ai. And this is really a new generation tool which I have used consistently. Otter would basically transcribe any interview that I could do on Zoom or Google Meet or Teams or any online platform. It would transcribe it in real time, and as soon as the interview was over, it would send me back a transcript. And the ability to do that, it was about 8 months after I had my stroke, that I was able to use this technique to start writing articles. And that just changed my life again because I felt I had whatever capabilities I had lost because of my stroke, I was able to reintroduce some of them into my life. A really major realization, and this I credit Deborah Myerson's book for helping me realize this, is that very often after a setback like this, people say that you should bounce back. In life, you can't really bounce back. It's not really possible to go back to where you were. What you have to do is bounce forward. You have to look at what your life is today, what you can do, what you can't do, which tools are available that can allow you to do what you can no longer do. And then if you use that in a creative and imaginative way, you can rebuild your life. This process has allowed me to re-engage professionally as you heard in the beginning. I'm now an associate fellow at Oxford. I'm involved in some projects there which are very meaningful about climate change and financial inclusion. I do a lot of volunteer work. Probably the most significant part of that is the work that I'm able to do with Stroke Onward, which is a nonprofit that Deborah Meyerson, whose book helped me so much, and her husband, Steve Zuckerman, they have founded. I work as a volunteer with them, and one of the great privileges was that they wanted to create come up with a second edition of identity theft. And as an editor, I was able to help them with that, work with them. And AI was a fantastic research assistant in doing this. To give you just one example, when we were trying to come up with the second manuscript of the second edition, they had about 5 years worth of columns on the American Stroke Association website. They were trying to figure out a way to integrate some of that content into the new edition. AI made it extremely simple because there's all this data. All we had to use AI in a creative way to get that information and to redo the manuscript. I'll say just a couple of things and then stop. I have focused on my own story because that's what I know best. And this is a first person experience of how I was able to use AI. I start with a human process of coming up with story ideas. Then I give to AI the task of transcribing everything, which is a very menial and mechanical task. And then I take back from AI and edit the final manuscript myself. And this workflow process of human, AI, human, that has allowed me to rebuild my life. And almost every person with a disability could be able to adapt the same process to regain control of their own life. And in that sense, this is not my story alone. It's a story of 800,000 people in the US who get strokes every year. And if you look around the world, according to the World Health Organization, 15 million people get strokes every year. So it's mainly for them that I wrote that essay. And if some of them are able to use these tools to regain control of their own life and to reintroduce meaning into their own life, then my purpose is served. And my final point is just this. If you look around what people are writing about AI these days, I think it falls into two big camps. On the one hand, there is the hype narrative. This is largely driven by the companies, the tech platforms, the venture capitalists who are trying to maximize their value of their investments. And there is an element of truth to what they are saying. The AI is transformational, as we all know. So there is some truth to that narrative. The second narrative is the doomsday narrative, which is AI is going to be a dehumanizing force. It's going to, cause huge risks, cause huge problems. People are going to lose their jobs. Layoffs will happen. That's the doomsday narrative. That also has an element of truth, which is why it is as prominent as it is. But there is a third narrative. The third narrative is much softer because there are no constituencies that are promoting it. And the third narrative is that if you have been disabled after a productive life by something like a stroke, and AI, if you use it correctly, can put you back to work again and can make life meaningful again. So I have tried to pay attention to that third narrative and try and amplify it as much as possible, not only by telling my own story, but also writing stories about others who are using technology to rebuild, to regain a sense of purpose and identity in their lives. I'll stop there. Thank you very much. Thank you for listening to me, and good luck to all of you.
Thank you, Mukul. This was really a great session, and there are so many issues that came up from your session. What I felt is, uh, I mean, there are too many takeaways, and there are some emotional part of it also, because we all know that uh, it's not just stroke, I think, because aging is also something we need to, because in the when we are working in the disability sector, we also have to think of aging. So maybe someone in the family is losing some kind of maybe eyesight or movement issues, and how AI can. And I think I was actually taking notes because I felt I need to write this. It is you can't bounce back, but it can bounce forward with the help of AI. And that is really something we need to see how it can transform, and AI to human, and then AI, then this whole uh, with it shouldn't be that that identity crisis that comes from a stroke, and the large number of people who acquire disability can actually be benefited from such uses. And I think we'll definitely want to listen, hear from you maybe sometime later. But thank you once again. So our next speaker is Abhiti. Abhiti Gupta, or L, is an independent consultant who works at the intersection of gender, sexuality, health, and law. Um, Abhiti are currently trying two initiatives: one to create support space for queer people navigating neurodiversity in workplaces and institutions, and another to share legal and practical knowledge from a human rights perspective. For anyone willing to get acquainted to the Indian legal and judicial system. A law graduate with a master's in women-centered social work, Abhiti has a decade of experience in sexual and reproductive health, rights, and justice work. One of the primary areas of Abhiti's work is advocacy centering access to safe abortion as a right to bodily autonomy. Abhiti also raises culture of specialization, continuously exploring areas they're passionate about. Currently, they are also practicing English to Hindi translation of feminist writers and practitioners to inspire Abhiti. So, over to you, Abhiti, and we'll come back with question answer session after Abhiti's speech is over.
Thank you, Shompa. I will share a presentation. Um,
Yes, Abhiti, we let you know once we see it.
okay, yeah.
We
Yeah,
can,
I hope it's it's visible, no?
you
Yeah,
make it.
thank you for
Yeah.
oh, thank you. I think up till now, I'm sure like we have sort of figured out the idea that like how artificial intelligence is definitely a big part of assistance and like an assisting device of in creation like for human mind. And of course it follows what is being fed into it. And yeah, and I think and it's important to also acknowledge that who are feeding into that knowledge, or who have the resources, or who are privileged enough to be able to reach at a place where they can uh, function on technological spaces, they can access digital spaces. So I think that's something that for me becomes like sort of important to to focus on. And another thing that I've like that I usually like figure out in life generally how so many times we believe a certain source or we believe a certain person, and when there is a space where the data and like information globally of like is available, so of course it is more likely that we will trust that source irrespective of what is an individual experience or what I'm talking about myself. So yeah, I think just keeping that in mind, I mean, a lot of conversations have already happened in like since afternoon. So I'll be very mostly brief and crisp uh, with my conversations. Um, Sorry, thank you. Hmm. So I will largely bring upon how what is assistive technology, because when we are talking about people with disability or people with different marginalized identities or oppressed communities, how technology can be a supportive space, um, but also for people who have been diagnosed or identified as uh, having some neurological disorders. So understanding that those disorders are not are mostly are they're not just functional, but they're also behavioral and emotional, and it can be any person. It doesn't have to be like a label assigned where there is an idea that okay, this person has ADHD, so every person with ADHD will have similar experiences or similar behaviors or similar emotional responses. And second thing will be like a basic essentials in my understanding what how assistive technology can be resourceful, and the gaps which are kind of recorded. There are data, like there is present data around those things, and some gaps which seemingly are unacknowledged or unaddressed, and some aspirations or some expectations that I have from a system like artificial intelligence. Um, yeah, so of course, I think this is also being said before, how there is a lot of like independence, a lot of agency in when you have a support system with you. And I mean, and for a lot of people, like for example, for a deaf person, most of the times, the you are being kept out of discussions and conversations. It's very easily said, ki, oh, this is not relevant. This is not relevant. You don't need to know about that. But like, is the person making choice whether it is relevant or not for me? So there are a lot of tools which do help in attaining that kind of position. um, you know, be equal participation, having enough opportunities to enhance like functional ability, and in terms of dignity, where uh, dignity in also terms of confidentiality. I won't say privacy, but like confidentiality, where for somebody it's hard to access any system, and it doesn't have to be any person with disability necessarily, like anyone who has to access email IDs, or they need to have email IDs, and you have to share your password with a second third person who you may not know. So these kind of like which are also, of course, we have experienced and seen uh, these experiences in physical form, but also in virtual reality, how they also are impactful. They also impact you as a person and reminding you of what the social uh, implications you have with your existence. Um, yeah, I mean there's definitely reduction of in care needs, and also with expenses, uh, and with opportunities for education and employment. There is possibility of less dropout rates, uh, possibility of getting more employment opportunities. Um, with respect to healthcare, I mean, a lot of conversations have happened, so I will not really, talk about that. But just like one thing that I wanted to bring in, where you know, in 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 my circle, in my understanding, a lot of people would also avoid going to a healthcare practitioner, because there is likelihood of being biased and stereotyped or put in boxes of a man or a woman. So I would prefer that I would do a virtual or like an AI conversation with for my diagnosis. If I'm dealing with something, instead of going to a person, because yeah, there is very limited human interaction, and that human interaction is likely to cause me more harm than maybe this machine who doesn't have emotions or feelings or anything to project on me. Yeah, some of the essentials is, of course, with respect to accessibility. And when I mean accessibility, it's not just about that I am able to uh, like regulate with it, like to use it, but also whether there are enough resources, what kind of services are being provided, is there what kind of knowledge creation is being done for more people to be able to access it. Um, and I think that is more or less the conversations which I feel are relevant also when we are talking about artificial intelligence, because then uh, the whole idea of the system is more in knowledge to a section of people who have a lot of privileges, who have opportunities easily accessible, or but like the kind of challenges that somebody from a marginalized caste, class, or religious identity may have. That is definitely going to vary in terms of being able to access a place. Um, and of course, with respect to knowledge and information, knowing how to use a system, like knowing how to use a phone. I mean, there is still time when, and I'll go back to like how it's very easy to trust a machine instead of other humans in most of the situations, especially for a lot of people who have lived with insecurities and self-blaming or like self-questioning. Um, and where like this machine is telling me something, I would just go yes, 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 instead of just like looking at what is it saying. So all of these things are, and it also becomes a reason, some like, of course, when there are cases of like financial frauds, or like fraud insurance schemes. So all of this is also comes as a matter with in comparison to like when there is very limited space or opportunity to have enough resources and information. Of course, physical infrastructure, affordability, uh, custom, uh, having them customized based on a person's needs. And it also becomes relevant when I myself am not aware of what my needs are exactly. So while I am figuring out my own needs, um, it is it is an added burden in a way when I am also figuring out how to function around people in a present situation, but also navigate how I am being perceived and how I am being addressed, or so all of that. They do cause a lot of they are likely to cause a lot of challenges for any individual. And yeah, I mean, one of the basic essential that I feel is that uh, all these departments, and I think I missed out, I realize I missed out a few here. Department of Health, Social Justice, Employment, Education, Technology, how it is important that uh, there is possibility of enough integration, uh, uh, and which makes it easier for people to access the resources, to be able to get their IDs done. I mean, from a very close example, from a very close knowledge, uh, like I do have my for somebody who have their TG identification card, but for them to, they also need to have their name or their other details changed in other for example PAN card, Aadhaar card, or passport, for example. So how these systems are not connected, and that, and I think that's where systems like this, like artificial intelligence, can be really helpful and supportive. So I think these are some really relevant things which might be going missing, or maybe they are happening, but yeah, uh, who all know about it. Yeah, the question of privacy has been discussed very, very deeply today, and there are possibilities, and like not just possible, there are biases and stereotypes which do get reflected. And even in case of somebody with disability, if it's a very physically visible disability, it's uh, the idea of that the person cannot make their decision, or there has to be somebody as an attendee or as an attendant in a health facility, that comes very naturally. It feels like it comes very naturally to the health practitioners, or to the team. And and when you're also, like, for example, I was hospitalized and I had to tell about my medical history and my present medication that I am taking, and that led to how I was treated in the hospital, not not for what I was dealing with medically, but what diagnosis they saw that I had earlier, which kind of they saw it as behavioral issue or some sort of emotional troubles that they perceived, and that reflected on their behaviors towards me. And yeah, I mean, and that makes you feel very irrelevant, and a lot of self doubts that may appear in those scenarios. So it's also important that that how, if that's the system that I have to deal with, which is biased uh, and like yeah, non-supportive, I would rather be in contact with an AI robot, or AI function, where uh, I can still be the person I am, and like not be judged, at least on the face of it. And yeah, I mean, apart from that, there has been when we're looking at like mobile ownership, because uh, a lot of access of artificial intelligence or assistive technology is are through mobile phones or laptops or computers. So the percentage of how many people do really have access to these resources. Um, so, for example, in India, there is like 33% of gap in smartphone ownership for people with disability. and women with disability do have like lowest level of mobile ownership. And here it was seen as a gender being the more prominent reason for that instead of a disability. And when in this particular report, when they're talking about also ownership or having mobile phones, it doesn't necessarily mean that they have their personal mobile system, or they do have like one system with them 24/7. It is more likely that it is used by the entire family. So also, of course, we come back to the idea of privacy and confidentiality for a person to have access to basic necessities for somebody with disability. This might be a basic necessity. Allocation of funds, accountability we discussed about, dependency, internet access. These are like conversations which are already sort of recorded.
I'm sorry to interrupt, but can we finish in 2 minutes?
Okay, sure.
Minutes, yeah.
Yeah, I mean, there is very limited consideration of physical, cognitive, and social barriers that a lot of people are facing. And while there is no universal system, or I would say there is no model as such, which gives a lot like different opportunity or different scope of like how assistive technology can be accessed easily for different people. um, and people who are, of course, who are building assistive technology, what is their background, where they are coming from, what are their experiences, uh, to make sure that the technology that they are building is accessible and helpful. And there is very much requirement of human engagement, like one-on-one engagement, for anybody to feel belonged, or feel loved, or feel like heard. Yeah, and like there is the idea of empathy is definitely completely missing. And yeah, this resource dissemination, threat of biased diagnosis, situations of internet bans and humanitarian crisis, which adds another layer of marginalization to a lot of people. And I mean, we are living in a scenario like that very clearly. And overtaking manual skills, I think that's I will just like go to the next slide, will not talk about it, but like uh, just the idea of like uh, uh, manual presence and manual skills being replaced by that. Of course, that's helpful, but expecting that there is possibility of using everything that's there is something which is, I think, important. And yeah, I mean, uh, yeah, I think I'll just stop there. And yeah, and I think last I just want to read, like, instead of trying to mainstream, it's better to broaden the idea of what's really normal, instead of putting everybody that, okay, this is this is what everyone should know. So why everyone cannot, like, be use sign language. Why a person who is deaf and mute has to be able to read through captions. And yeah, I think, yeah, I'll just like stop with that. I mean, if there's time, I will briefly like talk about the implementation of the two acts. But yeah, thanks.
Thank you very much, El. Yeah, we could take some of that during the Q&A, which is also, but very briefly before I move to the Q&A section, thank you very much, El, for that talk, but also for really expanding the dimension. Okay, I seem to have gotten muted automatically. But what I was saying is, thanks a lot for also sort of in expanding the dimensions and sort of giving a lot of depth to what we mean by when we talk about accessibility, and also how accessibility works or does not work in larger mundane everyday lives. I think that is one of the things that perhaps developers and deployers of AI technologies are not directly engaging with. And I think that was very, very helpful. Also, thank you very much for sharing that list of aspirations. And I think it is a collective task to also think about how to make some of those aspirations into actions. I think there are some questions in the Q&A box already, and Mridul has been very diligent in answering them directly on the chat. So I'll come back to those in case there's time. But Mukul, there's a question for you, and I'll start with that. Vrinda is asking, are there tools that can help a stroke survivor use AI to communicate across distances? And the person is somebody who could only operate a smartphone prior to the incident of stroke. So if you're aware of any such tools.
No, thank you. That's a wonderful question. Uh, it depends on how you are trying to communicate. The thing that worked best for me, and it still continues to work really well for me, is the WhatsApp feature where you can record messages. And the advantage of that is that if you're stroke, because of the stroke, you can't operate the tiny keyboard on the phone too well, which I struggle with from time to time. Uh, you can just press that button, record what you have to say, and the message will go through. And this is a technique that, in my case, has worked with people in different time zones, different countries. Because I'm here in the Princeton area in the US. Many of my friends are in India, a family in India, in other countries. The advantage of this technology is that it can work asynchronously. Now I know WhatsApp has a lot of negativity associated with it for some of the use of the way in which it is used for political purposes and all that. But those are not the only things. It's really up to us to see how we can use it creatively in our own contexts. You see, and if the person that you're talking about needs to use these features, that's what I would recommend.
Thank you very much, Mukul. Mridul, because you work with assistive technology development, do you have any more suggestions or responses to give?
I mean, so yeah, most of the communication apps and tools that we use, like what Mukul also said, they will only apply. I mean, the only thing that I would want to know is that is there a specific limitation after the stroke, as in uh, the fact that they're not able to talk to people using a phone. I mean, is there an issue with sort of speech? Are they having difficulty speech, or are they having difficulty typing? So if there's a specific issue that they're facing, then an alternate way can be used. But yeah, mostly the standard communication apps.
Thank you. Elle, anything from your end that you'd like to add?
No, not really. Thank you.
Thank you. There's another question. I'm sorry, I don't completely understand the question, so I'm going to read it out as I see it, and I would hope that one of you would be able to unpack it better. So, somebody's asking, how can we recreate the lived experience for more experience-based rehab using a virtual environment? So, if I understand it correctly, they're asking if there's a way to use a virtual rehab setting for a stroke survivor who's sort of in rehab and getting sort of the mobility help and assistance that they need. But again, I don't completely understand it, so I'll wait to hear from all of you on what you think about this.
If I could respond, I think the idea is an excellent one. The question is an excellent one. Uh, I do see a lot of virtual environments in which all kinds of things are being done, and the ability to use AI in rehab is a very good one. The I think you have to unpack which specific rehab activities would adapt themselves more easily to AI than others. I think for physical therapy and occupational therapy, there may be some aspects that may be possible. But I think that based on my experience, at least in the US, the medical system is extremely good at the physical aspects of recovery. For physical therapy, occupational therapy, speech therapy, to up to a point, they do an excellent job. The really missing link, and this is where the issue of identity came up. The missing link here is that a stroke is not just physical; it doesn't just physically disable you. It causes emotional, psychological, identity issues, and that's where I think AI can help a lot because that's not being addressed as far as I can see, at least in the medical system in the US. So the fact that you are able to regain some of your capabilities, are able to perform some of the things that you can do that you were not able to do before. The one example that I have recently found is that there are apps now that allow you to practice speech therapy. There's a lot of neuroscience research that says because of neuroplasticity, if your brain has been damaged after a stroke, you can actually rebuild those capabilities through practice. And uh, at least under the medical system in the US, speech therapy sessions that you can go to, maybe say 1 hour a week or 4 hours a month, something like that. But you may need a lot more rehab in terms of speech therapy. So if you use an app to practice, say, 30 hours of speech therapy on your app and then do 4 hours in the rehab hospital, that will dramatically increase the amount of recovery that you can do. And these are the kinds of ways in which AI can be used in rehab to restore capabilities, not just emotionally, but even regain some of your physical capabilities through. And I just remember Google is developing a tool called a Paratron because when people have aphasia after a stroke and the speech impediments, they are trying to work on a solution where you can where the app actually has been trained on people with aphasia. And so where you can use the app to give an order, say at a restaurant or at a McDonald's in flawed speech, and the app will translate your flawed speech into normal speech so that the person you're talking to can understand. So the sky is the limit when you go to this. And I would encourage you to explore all kinds of ways in which AI can be used in rehab.
Thank you very much, Mukul. Veena, just give me just 1 minute before I go to Veena's question. She had her hand up. I'm jumping the queue. I'm sorry, but Mukul, I wanted to sort of follow up on the previous question that in all this deliberation about AI use in helping stroke survivors recover, not just in terms of their occupation and their physical abilities, but also in terms of emotional and mental states. Where do humans feature? If you could also tell us, because you gave us this very helpful paradigm of human AI, human sort of yeah, I mean the human AI, human pipeline that you called. So if you could also very briefly touch upon where humans feature in the recovery process, that where you had a very intimate connection with AI in that setting. So yeah.
I, I'll come back to the point that I made earlier that the important thing is to use technology but not overuse it. See, if you don't use AI at all, if you don't use technology tools at all, then you know, you're going to remain the kind of funk that I was in. Use it up to a point, it will extend your abilities. In the same way that a crutch physically can extend your abilities after you're disabled, think of AI as a digital crutch. It can do that. But if you are completely dependent on the crutch, if you overuse AI to the extent that you stop trying to develop your own capabilities, then it becomes a disadvantage again. So too little is problematic, too much is problematic also, because what will happen then is that you will transfer your dependence from from other people to AI, and that's not good either. Humans need to use AI in a way that doesn't dehumanize you, but which actually enhances human connection. I've been thinking more and more about this recently. I think that's the right way to use AI. I can give you examples if you like, but that's what I would say.
No, thank you so much, Mukul. That's been deeply helpful, and your talk was really enriching that way. Over to you, Veena, if you'd like to ask your question.
Thank you for letting me ask the question, because typing wasn't an easy option. Now, as a medical doctor, my experience has been with women and their health. I hope I'm audible. And most of the time, women are not easy patients, easy in quotes, because they don't come and tell you what a doctor needs to know. For instance, that they work almost 20 hours a day, both at housework and at wage work and care work and a whole range of things. And the doctor isn't really programmed to go into details of that. Now, work itself can be debilitating if you've got a fever, a bad condition, whatever condition, muscular condition or back pain or whatever else. The details are not asked. The doctors would only ask for certain symptoms, which is you've got pain, no pain, so you are given your dolo or whatever is. Now, this is happening in the large parts of the country. And if we have such a situation, there's not, very few doctors who can bring out the reality of a woman's life. She hasn't slept the whole night because she's taking care of her father-in-law or mother-in-law, or the child was sick or the husband was sick. I mean, she doesn't sleep. She has to do all the housework. She's has to be present, beck and call, go and do her work, etc. No, shouldn't repeat it so many times, I know. But this is her life. And are we programming AI with this kind of background? I don't think the AI business is able to pick this up, because you have to feed this information. And if you don't get the information, you're not going to. So you will get a dolo, whether you're AI or you're general practitioner. The other end I find is Indian doctors do not record anything, will not write down anything. Everything is in their heads. So they see a patient coming and they can tell you this patient is going to deliver well. She is, they can actually diagnose her when she's entering the door. You have such sensitive doctors, but they don't publish, they don't discuss, partly because they don't know how to put all their data into a table form and share it in these big meetings where international guests are there. They're very ashamed of their intuition. So a lot of healthcare is intuitive, and very often they are right. So that's how you have a good doctor and a bad doctor classified. Now, I won't go on further. Under these circumstances, how is the AI going to learn to take care of our people in remote corners of the country? I mean, is it a very silly question? I don't know, but that's a reality of lots of people who will not be able to tell you that this is related to that. Just yesterday, I had a case where a woman says, my body's paining, my body's paining, my body's paining. You have to ask her again and again, do you have painful periods? Do you have painful micturition? Do you have fever? Because body pain comes with any illness. So it was like I had to sit her down and talk to her for 20 minutes before I got the information. So how will AI be trained for Indian conditions? Thanks a lot.
Thank you, Dr. Shatrughna. I mean, I'm smiling because I also trying to flag, but did it far better than I did. And I will ask my panelists who were smiling with me to respond. Elle, would you like to start us off? And Mridul, because once again, this is a question that's perhaps best answered by a developer. You could take it after Elle. I just want to say one thing that after that, we'll have to stop the Q&A and I'll hand it over to Shampa for the closing remarks. And then I'll come back at the end begging for some money to keep the journal going. Just giving everybody a sense of how things are going to look. All right. Elle, over to you.
Yeah, I think this just reminded me of a like friend telling me about how a lot of patients for her, like they expect to, like, oh, tell us to get some tests done. Don't tell us what we have. Like, just ask us to do some tests. And also on the other side, where practitioners who are maybe the current passing practitioners, I think the kind of intuition that Dr. Shatrugna was talking about, it's actually going missing because everything is dependent on these medical tests. And unless those tests say something, they will not have a conversation with the patients. And yeah, I mean, I don't really have an answer like how to train AI into that. But yeah, definitely you can't have a system do it just by itself. There has to be human involved. There has to be like primary care strengthened, like primary care healthcare system needs to be strengthened to use uh, these resources which are building up. Yeah.
Thank you very much, El. Mridul, over to you. As somebody who makes AI tools, you're probably the best informed on this table to tell us how can we work with doctors who neither record information nor ask those questions. Yeah.
I mean, how can we work with doctors? I will not be able to tell you because I have no experience working with doctors. But so the question that was asked, about how can AI be used, for example, how can AI be enabled for these specific decisions, that a doctor make this very specific understanding that a doctor will have after experience. The term that was used was intuition, right? That is apt, right? Which is what this sense of understanding that you develop once you have some experience, once you've listened to enough stories. So even that doctor who has developed that intuition must have developed it either because the doctor went through the same thing themselves, or because they must have heard enough patients come in and talk about the same thing. Uh, with AI, like with any data-driven system, it is only as good as the data that we give it. That is a known fact. And the thing that we were talking about earlier about, people who get left out, who all gets left out, and then that has these holes, these gaps in the AI agent that AI agent also doesn't know. So it looks like a very knowledgeable thing. It looks like, because it looks like very innocuous, very innocent, but it's actually just as biased as the data that got fed into it. It's just that if it's a doctor that is biased, we register it sort of in different ways. Or if a doctor is incompetent, quote unquote, in the sense they don't know what questions to ask, we register it in different ways. With AI, we have different expectations because there's no face to it. But it's actually just as good or as bad as a human in that situation. Uh, the way to overcome this is to obviously feed it with data. It's to feed it with enough data. One way that we can actually have doctors collect this data is to use these tools, which will do the filing, do the recording for them. Because as Dr. Shatrugna said, doctors don't do it because either they're scared to make tables, they don't want to put in extra time, they don't have the time. So probably some kind of tech there can be used where some base work can be done by some tool, and then the doctor can sort of put in the stuff that only they know, the intuition that they have, put in a little bit of notes, and then try to prepare some data set which can then be used. But yeah, I mean, it's not an easy solution. It's going to take time, but then that kind of effort needs to go in if we have to account for all of these sets of people that are getting left out.
Thanks a lot, Mridul. Mukul, any additions from you before I hand it to
Yeah, I have one very short comment, and that is AI is changing a lot, but it is not a panacea. And the most important thing that I have learned so far is to be very selective in what we use AI for and what we don't use AI for. And I'll just give you a very simple example. I mean, many people now use these driving apps when they go driving. And that's fine because it'll show you the directions where you want to go. But just because you have a driving app doesn't mean that you stop looking at the road. You see, there are things that humans can do better than AI, or humans can do that AI can't do. And there are things that AI can do phenomenally well. So being selective about what you assign to AI to do and what you retain yourself as a human to do. If you are a doctor, that seems to me to be a judgment call that humans should be making and not AI. There's a lot of AI development happening very, very quickly. AI is doing more than it could, but there are things that humans can do better. And the way in which I at least think about it is to do meaningful work, we need a combination of inspiration and perspiration. And whenever some task that I'm working on is closer to the inspiration end of the spectrum, I do it myself. But whenever it is closer to the perspiration end of the spectrum, I assign it to AI. So when you are relating to your patients as a doctor with empathy, and you don't want to lose that sense of intuition, keep that as a human task. Connect with the human as a human. But if you need to get AI to assess what their X-ray looks like, use AI for that. And then you will be able to see 100 more humans. That would be my suggestion.
Thanks, Mukul. I'm quite sad that I didn't take adequate notes when you were speaking, because there are some of these phrases that are worth printing on t-shirts. Bounce forward, not backward. Sorry, bounce forward, not back. Perspiration, not inspiration. I think some of those should be circulated as t-shirt quotes. But thank you very much for sharing that. Shampa, over to you for your remarks. And yeah, then we'll close.
Um, it's actually a difficult task to give closing remarks to such a fascinating. It was really fascinating session, and we got like totally different kinds of. I mean, the perspectives were so different of all the three speakers. Uh, but I think one of the most important thing that Mukul mentioned is use technology, but do not overuse it. So these are some of the lessons we need to, because we cannot say that we'll not use technology at all, and and we know there are some negative sides of it also. Yet, uh, particularly, I'd like to mention a little bit about what there was a lot of discussion on uses of WhatsApp. WhatsApp is one of the, I think, most commonly used uh, commonly used app for disabled people in India. What I found is, and particularly some of the features. One is this voice message, which a lot of blind people use, and this was something we as people were also used a lot for communication during the pandemic days. So because it was very difficult to get information on COVID and disability, and government was not giving us as much information that we wanted to. So there was WhatsApp was, I think we were using it like almost every day, like we're sitting and sending so many messages and keeping in touch with each other, which also I'd like to mention a little bit about mental health, which I think Mridul where maybe sometimes some of the messages are just we are just being thrown some of the ads or some repetitive things that which are thrown up to us sometimes. Uh, and how it affects our mental health is also something we need to think of. For example, very recently, the Sushant Singh Rajput case was again came up in media because the CBI asking for closure, and this particular case was like over and over, like used by all the like social media platforms were being used, and the photographs of a young actor who died by suicide was being like always thrown up on our face whenever you but we wanted to be in touch with others, so we couldn't say that we'll stop using social media because it was a pandemic time. And I personally recall that there was at least 2 or 3 young people who told me that they started ideating suicide because they felt that if this person is getting so much attention because of his death, then and that is something uh, I'm also feeling like because I want attention, so a person who's already vulnerable in a vulnerable mental health situation. So how do we uh, we use AI in a positive manner, and we need to learn that it's because it can be used in a positive manner also. So instead of just throwing up some negative information and using such photos which shouldn't be actually, which should not have been done. And this is something I think as people who are anyway marginalized in a setup where you are and I think I'm just going back to pandemic time too much, because that is also the time we used AI most of us, because we didn't have any option of human uh, uh, hmm, interaction. So do we have more time for questions, Shantan? Do we have to?
No, no,
Uh,
no. I was just going to be biased and I saw Chaya's hand up and I said, "Ki, okay, Chaya to is friend, so she gets to ask one. But then Chaya is telling me she doesn't have questions. So I am
okay.
safe from being biased.
Yeah. So, but yeah, but I'd also like to stop here. But I just hope we just, I mean, of course, like we are, I think, running late also, but we need to keep this conversation going. I don't know how and when and where, but it was such a fascinating kind of thing. And I also took some notes and hoping that we can maybe use some of this material for more articles to write, and also some more conversation and both I mean within our groups, and also I think outside this group who are attending today. But this was like and we also had amazing participants with all the intelligent questions coming up, and so over to you, Shantan.
Thank you very much, Hampa, for those wonderful remarks. So, on that note of writing articles and using some of that material, I just want to appeal that one of the organizers of this conference is the Indian Journal of Medical Ethics. It is a platinum open access journal that's been in some sense at the forefront of conversations around medical humanities, medical ethics, bioethics, which are all defined very broadly, by the way, since a very long time. And one of the things that we're struggling with, and I believe so are several other platforms, is how to mobilize funds to keep the journal going. We don't accept tobacco money, we don't accept pharma money. There are a lot of due diligence regarding how we want to work as a journal that's doing work around bioethics. And in these deliberations, we've realized that the most effective way for us to keep going forward in the model that we've been following, which is it's free for people to submit to and free for people to read, is that we trust the community and we go back to the community and we say, help us keep ourselves running. And that's what I'm doing. I have put the link in the chat. We don't ask for any amount of donation, whatever amount of money you can afford. And if you think that the kind of work that we are doing is worth it, please do contribute. And we wish and we hope that we'll see you again tomorrow at 4 o'clock sharp, which is when we have the last session and then the valedictory session of the 10th National Bioethics Conference. Thanks once again to Shampa for co-chairing this session with me, for Mridul, Abhiti, and Mukul for joining as speakers and for staying 15 minutes over time. Thank you very much.